And I can imagine that some people might do a laryngoplasty for a smaller hole. Would anybody prefer to do a tympanoplasty approach for this small perforation?
You know, if you look at the drum, it looks like there's significant laryngosclerosis, and you know, some people like leaving that. I think it's non-vascularized tissue, and so I prefer to try to remove some of that. And you could still do that with a laryngoplasty approach, but for this, I probably would do a tympanoplasty and try to at least remove some of the tympano around the perforation to make sure my graft will hopefully adhere. But there's certainly lots of different ways of doing things.
Yeah, sure. So in this particular example, obviously there's quite a lot of laryngosclerosis which might influence our choice of procedure. Supposing there was we've had some less laryngoplasty kind of approaches. Anybody would do a pure push-through laryngoplasty for this procedure?
I think I'm sort of one of the newer surgeons to be doing this regularly for about a year and a half, and I think one of the things that I weigh is doing
the ossicular chain as well. I would agree with Dr. Meyer. This is a challenging location to do an underlay tympanoplasty one-handed, and as a relatively a new endoscopic surgeon myself, I would like to explore the area, explore the ossicular chain, but I would probably have a low threshold for trying the laryngoplasty technique.
Yeah, I think those are all great points. I say yes.
Yeah, and I would remark that, okay, if the airborne gap is okay, it's not too big, okay? In these cases, I usually touch the meningosclerosis, because sometimes, if it's not attached to the handle of the malleus, you can easily one-handed remove the skin from the edge of the perforation, and you can use a modified butterfly technique. You can remove a little bit the perichondrium of the cartilage, push through the cartilage to the perforation, and after that, extend the perichondrium over the meningosclerosis. It would be a great addition if you don't have an airborne gap or you don't have a handle fix.
Thank you. So I think.
One more comment is it's a challenging location from a simple standpoint of it's like perforations that are adjacent to the malleus I find are more difficult, and those I actually like to elevate some of the skin off the malleus next to the perforation, because I worry about skin tracking around the malleus. And where the endoscope is uniquely suited is that you can look. So if you don't have a large anterior canal overhang, even if you do, you can look at the anterior aspect of the malleus endoscope and make sure that there's not skin tracking.
First few I did, I had some disappointing outcomes with residual perforations, some laryngitis, and it never really, for me, looks very good. So I wonder if I'm just doing it wrong. Have you got positive experiences with the cartilage butterfly graft? Who would approach this with a microscope, or would anybody use a microscope? Yeah, and why is that, Aaron?
So much of my experience and training at the Mass Eye and Ear Infirmary was microscopic based. And I happened to be there when we were first introducing the endoscope and was really fortunate to benefit from that. But I still have certain types of cases similar to this, a subtotal perforation, that I have a higher confidence level in doing a post-auricular total drum replacement. So with split thickness skin grafting, it's a technique that is well established and used quite often at the Mass Eye and Ear Infirmary. And so I have usually used that technique for large perforations such as this. Usually quote around an 85% take rate, but we don't have as good of hearing outcomes. I can close the hole, but I would say that when we look at our outcomes, our airborne gap, especially in the low frequencies, is usually around 15 dB, and we do have some high frequency drop, and that may be because of the associated drilling that's necessary in order to perform canalplasty. And so I have to have a very frank conversation with the parents, but in my hands doing a large perforation such as this, I wouldn't feel comfortable quoting